Good morning, everyone. Sorry for the delay, having some technical issues here. I hope you can all hear me. This morning, I am very happy to introduce Dr. Maitland, who is visiting an associate professor who is visiting us from Medical University of South Carolina. And she will talk to us about mast activation and sickness and health. Thank you so much.
Thank you. Good morning, everyone. Oh my. Um, maybe my mast cells will wake up too. I'm definitely a New Yorker, so I'm going to try to not do this in a New York minute. But we're going to be talking about a cell that was actually identified in the mid 1800s and really didn't get a job until 1989. Which is a shame. These are my disclosures, and it really doesn't have much to pertain with this conversation. So the objectives, we're really going to be talking about the role of mast cells in health and their central role as first responders at the borders in tissue defense as well as tissue repair. And then we'll talk about our favorite topic. I'm sure all of you have so much fun when a patient comes in and says, I have MCAS. And then we're going to review the body of growing body of literature showing that we really need to start endotyping and phenotyping this cell population, just like we do for T cells, B cells, monocytes as well, because it's a very diverse population, and that will lean into just talking about some of the future research needs. So this is just really two very good resources talking about mast cell disease. This is just letting you know that literally mast cells have been thought about for close to 140 years, and we really didn't get an appreciation of how the multiplicity of this cell population. Just to give you a basic idea, and I'm going to start off with one of my favorite albums. I feel like I'm a miseducated allergy immunology specialist when I first was introduced to mast cells. And the reason why that was the case is we were really just taught like one thing, and I entered my formal training in 2000. And that is that mast cells essentially just did one thing, and they had IgE sitting on the surface, and then it would, the IgE would recognize some allergen, whether it was an environmental, food, medication, and then would trigger a release of histamine, tryptase. Sometimes you should know, for instance, that tryptase is never released or hardly released in food-induced anaphylaxis. So it makes it a very difficult anaphylaxis is actually quite complicated to diagnose in the emergency department, and there's plenty of literature to support that it's underdiagnosed and undertreated. So essentially what I was taught to do is if somebody comes in with any one of these complaints, you skin test, you get immunocap, and then, if it's environmental, you might offer allergy shots in the next patient, especially since the group that I worked at initially, I was seeing close to 20 to 25 patients a day. So it really didn't leave much for a conversation. And the reason for that is although mast cells were identified in 1866 in frogs, and it was in late 1880s that it was identified in humans in every part of the human body. We really didn't think about mast cells at all until 1989 when they identified the relationship of IgE to mast cells. And that was actually during the rising epidemic of atopic disorders, so rhinitis, asthma, food allergies. And this is actually my syllabus from the Quad AI annual meeting in 2002. And I wanted to show you that all they focused on in context, it wasn't mast cell disease. It was all about what makes an antigen an allergen, entire conversation. And that was despite the fact that they actually talked about eosinophils in the context of health and disease. That was the conversation. And so I wanted to kind of give credit to some of the professors that I've had the pleasure of working with along the way. That's K. Frank Austin and Al Sheffer, who taught me about the slow release substance of anaphylaxis. And Al Sheffer was instrumental in raising my awareness about hereditary, at the time it was called hereditary angioneurotic edema. Again, affecting women, and had tendency to they couldn't diagnose it, so they basically said that the woman is anxious or crazy. And then they open her up and like, oh my God, your gut is like completely swollen. So, and then Mariana Castell has been involved with mast cell disease in the form of systemic mastocytosis for over 25 years. And Dr. Shepard, which was very funny, this was before they actually had like a true map. So basically, I went in and said that I'm interested in going into allergy immunology. He said, okay, you start, June 20th. And he found out that I had cold-induced urticaria. And he's like, are you carrying an EpiPen? I'm like, why should I carry an EpiPen? I just, a little itchiness when I swallow. And he's like, no, you need to carry an EpiPen. And so that's my first introduction to physically induced triggers of mast cell degranulation. So here's another pathway that's been identified as well. And then we talk about angioedema again, and at that time it was only type 1 and type 2, and now we're up to type 3 with various variants. And unfortunately, it's going to take the insurance companies a bit to catch up on the diagnosis codes. But right now we have 3 major pathways that were identified by the time I was going into the working world as a community allergy immunology specialist. And then Brigham and Women's, NIH, and Stanford were probably the leaders in the diagnosis and management of systemic mastocytosis. And this is to show you that this formal protocol for the diagnosis of systemic mastocytosis only came around in 2016. So we're still working on getting better working diagnoses to get patients the information they need to understand the disease that they're dealing with, and also to provide us with the tools to come up with therapeutic interventions as well as prognostic indicators for these patients as well. So this is essentially what we knew about the receptors when it came to mast cell degranulation. And by the way, mast cells actually release chemical mediators 2 different ways. They have de novo production and they have degranulation. And there are now at least 4 phenotypes of anaphylaxis that have been described, 2 of which do not involve degranulation. So mast cells are extremely complicated in how they decide to release their chemical mediators. And they're also, there almost has to be a danger signal before you're going to have these very potent chemical mediators floating around. You're including enzymes, heparin, platelet activating factor, and interestingly enough, even tumor necrosis factors in the granules of mast cells as well. And who kind of woke me up out of my dreamy state of the fact that mast cells do more than just allergen-driven mast activation was this little boy. This is in 2011. He came to me, and I was the 11th allergist that he had seen. And he had been doing urticarial issues when he first came onto Mama Earth. And when I met him, he was flushing. He had already been treated in the emergency department for 6 cases of anaphylaxis. He had neurocognitive developmental delay more recently. And so the mother found out about me because I trained at Brigham, where there was known to be dealing with mast cell diseases. She says, I think my son has mastocytosis. And I'm like, unlikely, it's very rare, but let me listen to the story. So what I found out was he had been evaluated by all these doctors who all said he had allergy. I'm sure you also see these referrals as well. And then the allergist was like, no, I can't find any IgE whatsoever. And they basically said, we don't know what's going on. He's probably going to outgrow it. And it's pretty hard to tell someone, especially these are very savvy parents, how are you going to outgrow it if you don't know what's happening? The one thing I could tell you about the little boy, and I trained him in internal medicine, but I found it unusual at the age of 4 or 5, he was sitting on the floor in a W. And it turns out he actually has Ehlers-Danlos syndrome, and so does his mother, his aunt, his cousins, and we're still trying to appreciate that relationship on what might be going on. But that, per se, was kind of me really being introduced into the crosstalk between the nervous system and the mast cell compartment when it encounters physical triggers. And this actually became even more pertinent with the Nobel Prize winning professors who identified the role of CYP-V receptors to actually detect chemicals, including antigens from dust mites, from staph and strep, that actually can signal to the somatosensory network that will then unmask the mast cell. And so it's very interesting that we're starting to now appreciate the 2 systems that are responsible for surveying the borders that deal with the environment. So, a little question. Does anybody know the relationship between mast cells and feeding? Well, the gentleman who discovered mast cells, he actually labeled them that zone because he felt that these were well-nourished cells. Like they were feeding off of they're feeding off of the surrounding microenvironment. But he found that these mast cells, and he was able to identify them because the mast cells have such basic chemicals inside their granules. They just soaked up the aniline dyes that was from the German textile industry in the 1800s. And so basically, when we're talking about mast cells, they're fat not because they're living off the environment. They produce chemicals in order to help maintain the environment. And so this is some of the early studies that talked about mast cells. They're actually been identified even in sea squirt, which is the picture on the right-hand side. And resting mast cells, unlike ones that you might find in systemic mastocytosis or hereditary alpha-tryptopenia, mast cells that are in a resting activation state, I know that's a contradictory term, but they're always secreting things. It's just a question of what they're secreting and why. They're round, and they're basically solitary soldiers. So when you start seeing them spindle shaped out, or they start to cluster, they're seeing something. Whether what they're seeing or they're responding to is a false alarm or not, that's something else we need to get into. He also, Dr. Ehrlich also identified that mast cells are actually every single part of the body. And up till about 10 years ago, we really just divided them based on whether or not they had kinase in the granules and whether they were located in the connective tissue or the mucosa. So we have to go much further to try to understand the cell population that has been found in every single human. There's not a single report of an individual being born without mast cells. You might see low lymphocyte counts, you might see low neutrophil counts, but there's never been a report of a human embryo coming to vitality or viability without mast cells functioning properly. And also, another thing that I was taught originally was that mast cells arose from the bone marrow, but as it turns out, they actually arise from the embryonal sac and then populate the bone marrow. So this might explain why individuals that have systemic mastocytosis may not have bone marrow environment, because it's actually arising from a progenitor cell that might have been outside of the bone marrow, which will make it, again, very complicated to identify individuals that have clonal mast cell diseases because the bone marrow might not be involved. So you really have to come from different angles to try to understand whether your mast cells are misbehaving or not. Kind of like looking, just like we look at troponins and CKs and EKGs for somebody having a heart attack, you need to do the same thing for a quote unquote mast cell attack as well. And then this is just to show you that we've known some of the potent chemicals that were in the granules dating back to the 1950s. But despite that, this was the article that was in Lancet in the 1950s. They still didn't know what these cells did. And then this is just summarizing all the different discoveries that have been put forth in the literature regarding mast cells. Histamine was identified in the early 1900s, but was only found in mast cells in 1953. They found prostaglandins, again, later discovered almost 30 years later. This is some of the work that Dr. Austin had put forth in his early works. Samuelson identified leukotrienes. Mast cells were found to have cytokines in the granules, including interleukin-6 and interleukin-4. So it depends on where the cells are. You can see different compositions of the chemical mediators in different mast cell sets. So what you might see in the gut might be different than what you might find in the brain. Interestingly, all of these were mostly focused in the area of hypersensitivity, but the one person who had been doing mast cell research outside of immediate hypersensitivity disorders was Dr. Galley, who's out at Stanford. And his work really kind of stayed in the background because, again, in 1967, Ishizaka had identified IgE from a circulating individual who had IgE lymphoma. And then the relationship between IgE and mast cells was put forth in 1989, which was smack in the middle of the rising epidemic. And just to give you an idea, I graduated from college in the mid-1980s. New York City was in the midst of 2 pandemics, believe it or not. Mayor Koch, and this is something that Dr. Platts-Mills had put forth, was about to claim asthma as the #1 health hazard in New York City in the 80s until 500 men died from a disease that was finally labeled HIV. So some of the work that Dr. Galley had put forth was he was saying that mast cells, because of all these observations in the world of hypersensitivity, have been forgotten regarding their role in tissue defense, especially if you think about individuals who are in outside of industrialized nations are dealing with what? Mostly parasites, which might explain why there might be more T2 dominant phenomena if you don't have other infectious agents that would call in a different type of inflammatory pathway to deal with that type of pathogen. But he basically said we need to think about the fact that mast cells must do something more than, developing an IgE leukemia and dying from it. And so some of the observations identifying different mast cell activation pathways is the work from Chem Aiken when he was at NIH. And it was actually a very interesting story. It's nothing like going to a Brigham Women's reunion and hearing gentlemen after they've had some libation share the old war stories. And basically what had happened with Chem Aiken is that there was a physician who felt he had systemic mastocytosis. And he went to NIH and they looked and looked and looked, and he did not have systemic mastocytosis, but this was the first observation of case series of individuals that had monoclonal mast cell activation syndrome. And we're still trying to understand, are these individuals at risk for progressing into systemic mastocytosis or not? So that's another research effort that is underway. Then we had the identification of vibration-induced urticaria. So this was the first pathophysiology that was identified for inducible urticaria. And by the way, not only do these individuals have urticaria, in some instances they're actually at risk for having vibration-induced anaphylaxis as well. And then you also had the observation, again at NIH, where Joshua Milner and Jonathan Lyons, identified, looking for a marker for genetic atopic disease, were able to identify individuals that had elevated basal levels of phenotryptase. And that led into the discovery of hyperalpha-tryptophanemia, which interestingly enough affects 5 to 7% of the Caucasian population. So this seems to be a retained mutation. And my question to them was, why do you think nature would retain that? And again, I think it might have been a more effective gene population when you're living in an environment that you're at risk for whatever what tryptase can go after, such as some of the work that Dr. Galley showed was kinase and tryptase have the ability to deactivate venom from plenty of if you ever watch Jumanji, you can just think of getting bitten by a frog, for instance. They have the ability to deactivate that venom. So that would be, again, a selective advantage in that environment, but not necessarily a selective advantage in a westernized, industrialized nation. And I would recommend kind of reviewing some of the work that's been done recently by Brian Kim at NYU, as well as Caroline Sokol at Mass General. What was really interesting in the mastocytosis population, there's this article called The 1,000 Phases of Systemic Mastocytosis. And several of them would say, I would have large local reactions or anaphylaxis to stinging insects, but including mosquitoes. And Caroline Sokol took that even further and actually found out that the venom was being detected by the somatosensory neuron, not by the mast cells. It is the somatosensory network that seems to be sensitizing the mast cells to go down that T2 pathway, all depending on what the somatosensory nerves are seeing. So now we're having the mast cells basically acting as first responders to danger signals. And depending on what they see with the various array of pathogen receptors that they display, will then make the decision on what chemicals they're going to release. And not each time will they release histamine, or for instance, if you go through the toll-like receptor, there's no degranulation. So if the mast cells engage a pathogen through the toll-like receptors, you just have increases of interleukin-6, interleukin-8, and other cytokine profiles, but there's no enzymatic release at all. So we basically went from, in 2000, 3 receptors on the mast cells with the complement receptors, the IgE receptors, and the IgG receptors, to now several receptors. And one I would definitely highlight is the MRGPXR2, or what's called the MERG receptor. So this is the receptor that's actually responsible for recognizing very large molecules like vancomycin. And there's an array of these receptors, but if someone's going to have Bredman syndrome, that is going through the MERG receptor. If they have an intolerance to fluoroquinolones, that is going through the MERG receptor. And now there's a very robust research in place to try to identify substances that are much more likely to cause anaphylaxis in individuals with certain types of MERG receptors. Because they're still trying to understand the various variants. And we do understand that there are subsets of mast cells that have different MERG proteins, which might explain, again, a different phenotype of encountering an antigen orally as opposed to intravenously. So when it comes to the chemical mediator release, I would also point out the relationship between the nerves and the mast cells. And I think the most popular medication you might be aware of now that is a crosstalk between the somatosensory network and the mast cells is actually CGRP. So if you think about all those migraine medications, that actually is diminishing the conversation between the somatosensory network and the mast cells. And that's been a huge therapeutic advantage for patients that have migraine disorders, whether you're talking central nervous system or even abdominal. So I'm going to lean into the hypersensitivity. I'm going to call it the hypersensitivity epidemic as opposed to the allergy epidemic, because you really, when I hear allergy, unlike the original term of allergy, which came from von Perk back in 1902, where he says you have an antigen that encounters the immune system and you have a change. A negative change is you are having hypersensitivity and not clearing the pathogen. And he had noticed that he felt that was the first time there was a report that the immune system was actually causing disease as opposed to trying to counter disease. And then we kind of migrate into, well, we're seeing this huge rise in hypersensitivity disorders, which really has only been a phenomenon toward the last half of the last century and now. Adkis, who gave a wonderful talk at the Quad AI this past year, talked about the fact that maybe the reason why we're seeing such a rise in hypersensitivity disorders is what our borders, that old phrase of you are what you eat. Well, actually, it's what you breathe, what you eliminate, what goes through your skin, which may be influencing the first responders that are surveying the connective tissue that's exposed to the environment. And that includes the somatosensory nerves, which again have receptors for dust mite, have receptors for staph, have receptors for strep, and also very certain type of chemicals. And that in turn educates the mast cells. And I can tell you, I have at least 3 children that came to me probably around including the little boy that I had showed, who were having anaphylaxis and rhinitis and gastrointestinal distress, and had been treated actively for asthma on many occasions. And the IG level was less than 10. And then, and this is actually quite similar to the studies for the CAMP study that looked at individuals that had asthma before the age of 6, and then they would control the symptoms with either an inhaled corticosteroid or a cromolyn metabolite. But interestingly enough, it would control the symptoms, but it would not stop the progression of an IgE-mediated disease. So it seems that you start off with a non-IgE, serologically negative T2 inflammatory response from the environment, and then because you're continuing to control the symptoms, that you're not preventing progression into a locked-in T2 phenotype. And this is what happened with those 3 children. They all were having hypersensitivity reactions. They were under the care of other allergists that would repeatedly test them, and they would be repeatedly negative. And about 3 years after I originally met them, they all had significantly elevated IG levels. So that's how the immune system, or the neural immune system, is learning how to deal with the environment. So we're going to talk about border patrol and the role of nerves and mast cells in recognizing various environments. And this is the argument that Adkis had put forth, is that our environment has been completely changed in less than 40 years. And these exposures are causing danger signals to essentially be put forth out of the injured epithelial border. And then it is the somatosensory network and the mast cell compartment that are re-educating themselves to deal with the new exposures. So we're going from the classic type 2 IG mediated issue where you have immediate and delayed release. But I also have to tell you mast cells will degranulate, but there are two different types of degranulation patterns. And this is why you might not see corticosteroids effective in some pre-medication for patients that are susceptible to hypersensitivity reactions. And I'll get into that a little bit more. But I just want to highlight the fact that mast cells for a very long time were portrayed much more downstream, but they're much more proximal to the epithelial border. And they have receptors that detect, for instance, interleukin 31, interleukin 33, that goes to prime the mast cells to say, look around, there might be something going on. And then upon recognition of a danger signal, and then recognition of a pathogen, it'll release a different cachet of chemicals to deal with that pathogen. This is to identify that depending on if you go through the FC receptor or the complement receptors, you can see that there is degranulation with the release of proteases and histamine, as well as de novo production and secretion of cytokines and chemokines when you go through the complement receptors or the FC receptors, but that is not the case if you go through the toll-like receptors. And toll-like receptors have the ability to recognize, for instance, SARS-CoV-2 and other viruses as well. So that's why you might see release of tumor necrosis factor and interleukin-6, as opposed to seeing tryptase. And this is considered a mast cell activation event as well. And this is also to emphasize that depending on what the mast cells see, they will release different chemicals in order to contain the danger and call in appropriate help. So if it sees a bacteria, it's going to release certain types of substances that are that will help contain the danger, but then will release tumor necrosis factor to call on neutrophils. If it's seeing parasites, it'll release interleukin 4, 5, and 13 to call in eosinophils. And interestingly enough, the degranulation pattern is the mast cells will degranulate with intact granules that will then travel to the lymph nodes and then explode. So that's when your steroids will be effective. But if you go through the MERG receptor, the mast cells just explode. So giving steroids will not necessarily prevent a delayed hypersensitivity reaction when you continue to expose them to something that may trigger a reaction in the first place. So this is why it's really important to understand the pathophysiology of the various forms of mast cell activation events in order to have more appropriate therapeutic interventions. And this is the paper that came out almost 4 or 5 years ago, which shows that if you go through the toll-like receptor, I'm sorry if it's not as clear as it could be, but if you go through the MERG receptor, it's like those, if you ever go to see fireworks displays, some will go up and just explode, and some will go up, you'll see a little bit of something, and then they'll travel a bit more and explode. So if you go through the complement receptor or the immunoglobulin receptors, it will be released intact to have a little bit of activity, but they travel and then explode in the secondary lymphoid organs, as opposed to going through the MERG receptor. So we have an array of pathogen receptors. We have an array of dangerous detecting signals on the mast cell surface as well. You have different degranulation patterns and different secretion patterns. And we need to identify, no different than what we've done for T cell subsets and B cell subsets. We need to understand that these cells are trying to perform tissue surveillance, and then after containing a danger, help with coordination of tissue repair. It's kind of like a police officer, if you've ever been to New York City. I'm sorry, I just don't know Seattle very well. But a police officer who goes to rookie training and then gets assigned to, Little Italy as opposed to Harlem, the police officer has to be familiar with that community to better serve the needs. That's the same thing with the mast cells. They form in the bone marrow or in the organ systems where they're from the embryonal sac progenitor cells. They travel in small frequency. That's why you really don't see mast cells in a typical CBC with a disc. Yep, and the only way you can detect them is essentially with special staining, FACS analysis, and you can also use the high sensitivity PCR for the D816V, because it'll be there. It'll just be much, much lower than a person who's affected with systemic mastocytosis. But they're largely tissue based, and that's why that might have contributed to their lack of robust studies for over 100 years. And just to give you an idea of what these different chemicals can do, so they have the ability to release uh, cathelicidins, which actually have direct inhibitory effects on certain pathogens. They have the ability to release chemicals, chemokines, and cytokines to call in and activate various innate and adaptive immune cells. They have the ability to release platelet activating factor and heparin. I've treated 2 patients who've had disseminated intravascular coagulation after an anaphylactic event. And that goes to show you the ability for mast cells to change blood flow as well. And then they also have very potent enzymes that can help with tissue remodeling. And there's actually quite a bit of information regarding mast cell participation in fibrosis, especially, as well as in, oh man, sorry, senior moment. Fibrosis. It'll come back to me. So to sum up what mast cells are thought to do, besides developing IgE and having you have anaphylaxis or asthma exacerbation or hay fever, actually it's always not caused by hay and never causes a fever, but it's a term that needs to be changed. They mast cells sit right up at the epithelial border. They have an array of receptors to detect danger and also try to decide what usual suspect is causing the problems. And then they can release chemicals to try to contain that danger, as well as call appropriate help, including the ability to crosstalk, which mast cells can present to T cells. They have MHC to do so, and they also have the ability to educate dendritic cells, which then migrate to the lymphoid organs to recruit a more adaptive help. And then again, after the danger is bless you, put under control, they have the ability to help coordinate tissue repair. This is just to give you a different view of the essential role that nerve mast cell interactions play in barrier function and homeostasis. And if that barrier continues to be irritated by, like, I had a child that looked like they were having atopic dermatitis at 2 years of age. And it turns out the mom was just really using a lot of soap to clean the bottom nipples. And it was the soap residues that was on the bottom nipple that was actually contributing to the rash. And because it was irritating the skin so much, it allowed antigens to go in, and then that allowed the child to become sensitized. So once we got rid of that, and that's why the emphasis right now is really talking about what is the barrier doing, what is the microbiome doing, so that we can potentially slow down the progression into a certain locked-in phenotype and possibly reverse it. And these are the 2 papers that have been put forth by Adkis and Platts-Mills, talking about the role of our complete changing environment that may have contributed to the development of this immediate hypersensitivity. Not only immediate, there's plenty of data that shows that mast cells may not necessarily be contributing to the initial start of a delayed hypersensitivity disorder like myasthenia gravis or rheumatoid arthritis or lupus, but they can also help perpetuate it because the antigens are still out there. And if there's a danger signal and a protein, it's going to be a case of mistaken identity, and that's the ability of mast cells potentially contributing to the perpetuation of development, and as well as ongoing irritation of a delayed hypersensitivity disorder. So I hope I've given enough information to you to think that mast cells are kind of like good cop, bad cop. I'm a big fan of Sesame Street. But it all depends on the situation. No different than a police officer. If a police officer gets called, it's 911, what's your emergency? They're going to look around. And unfortunately, and it's probably not a really good example to use at this time, but sometimes innocents will be injured by the actions of meaningful, well-meaning surveillance. So mast cells are closely associated with the epithelium, contributing to barrier function. They're tightly regulated in order to prevent pathology that's associated with both immediate and delayed hypersensitivity disorders. This is just kind of giving you an overall picture of what mast cells can do, depending on what tickles the surface area and then what chemicals they release. And there are different caches and activation pathways. And one activation pathway does not necessarily mean another pathway is going to be interfered with. There was a great article by Dr. Carter on Dr. Golden talking about anaphylaxis, mastocytosis, or something else. And this poor gentleman actually had systemic mastocytosis, hyperalpha-tryptophanemia. He developed allergen-specific IgE to environmentals and venom. And the poor guy, guess where he lived? Tennessee. Alpha-gal. So let's talk about how we diagnose mast cell activation disease. So, and this is kind of leaning into what I thought was going on with Sean. So I would say after the development of, or the recognition of allergen-driven mast cell diseases and basophils, if mast cells don't get enough attention, basophils definitely don't. I would say in 2010, that's about, what, 13 or 14 years of just a lot of testing and still seeing people being symptomatic with negative testing. A World Health Organization mast cell working group got together and decided, look, we need to rename this and not use the term allergies, because that, again, is just one way mast cells can be activated. So they came up with the term mast cell activation syndrome. And it's a very simple formula. Is someone having recurrent signs and symptoms that mimics or resembles mast cells misbehaving? That's the best way of putting it. With those events, can you document that there are factors that are specific to mast cells contributing? And to be honest, out of all the things that we can test, tryptase is the most specific, and it doesn't get released in a lot of the reactions. So that's why we have to come up with other diagnostic approaches. And then, like we do with asthma and we do with coronary artery disease, can we give a medication that we know targets the mast cells or mast cell-derived mediators that may be contributing to their symptoms and gives them a little bit of benefit? That's only to diagnose whether or not mast cells are forward in causing the symptoms. It's not telling me why it's happening. And that's why another question needs to be addressed. So these are the signs and symptoms that we typically associate with mast cell activation syndrome. Interestingly enough, and you see this in a lot of the studies regarding systemic mastocytosis, top three: skin, gut, and neuropsychiatric. But interestingly enough, bladder pain syndrome or interstitial cystitis is a mast cell disease. Some joint pain is related to ingestion of foods, for instance. And some individuals that have pre-existing hypersensitivity disorders can have exacerbations in season if they're sensitized appropriately. And then you have, and what's more confusing, and I'm sure you're encountering a lot of these patients who are coming in with constitutional symptoms, when they talk about fatigue, who isn't tired? Have some more coffee. Anaphylaxis, and again, I would say emergency departments may be batting not as close to the Mendoza line, but they may be batting like 1 out of 3 when it comes to diagnosing anaphylaxis. I can't tell you how many patients. I was in the emergency department with my mother who had contracted influenza A, and I was in one of the hospitals in the Bronx. And a young lady came in who had anaphylaxis in the dentist's office. So, it's pretty bad. The dentist has to use EpiPen in their office and send them to the emergency department. And I'm standing right next to him, Mast, because this was right after the pandemic opened up, COVID pandemic opened up. And I hear him saying, well, whatever you got in the dentist's office, just don't get it again. And I'm like, okay, I'm going to be rude. I introduced myself, identified. You have 8 faculty members here who are all allergy immunology specialists. This person needs to be referred to allergy immunology to figure out exactly why that happened. And by the way, he's still wheezing, so get some albuterol. I mean, and it was incredible. This was a resident, and mind you, this is like, the end of their internship year, and doesn't even relay that information to the attending. So now the attending is not giving sufficient guidance on how that diagnosis as well. So again, here are the signs and symptoms. The signs and symptoms can be chronic or acute on chronic. It can typically, again, GI, skin, Neuropsychiatric can be brain fog, headache syndromes, and also, I don't know if any of you treated somebody who says they have an impending sense of doom. So that's blood flow affecting central nervous system functioning as well. When it comes to the issues with, then you want to look at the mediators. And I have to tell you, there's an alternative diagnosis, kind of like watching DC Comics. There's an alternative world of proposed criteria for systemic mastocytosis and mast cell diseases. And they use chromogranin A and heparin. There's no data to support that. And nor does that give you guidance on what therapeutic interventions you're going to use to try to help these patients reduce their susceptibility to these events. The gold standard is tryptase. I would say the close seconds are the 24-hour urine collections of methylhistamine, prostaglandin, and leukotriene metabolites. Interestingly, in New York, we're not allowed to get those tests. So we're kind of handcuffed in identifying these individuals. But by definition, this is a tissue-based cell, so you need to look in the tissue. So I have a lot of conversations with gastroenterologists. As a matter of fact, the first cohort for mast cell activation syndrome was a joint effort between allergy, immunology, and gastroenterology at Brigham and Women's. They simply went into the GI clinic, IBS GI clinic, and asked, do you have any other symptoms besides the alternating diarrhea and constipation? And interestingly enough, they identified 3 individuals out of the 18 that were reported that had anaphylaxis. Rhinitis was quite common, and the third most common was, again, neuropsychiatric. So it's important to kind of evaluate somebody coming in with fatigue and brain fog. It's on the differential, no different than if you have somebody who has osteoporosis at an early age. Looking at a clonal mast cell disease is on the differential. This is showing the data from that study, and basically they identified a couple of individuals with HAT. So when you see that tryptase above 11.4, and there were 2 at 14.4 and 19, this is a person who needs to undergo genetic testing to see if they have multiplication of the alpha tryptase gene. Also, looking in the gut, looking in the skin, or looking in the bone marrow will help secure it. These are some of the issues that are associated with it. It's extremely difficult to get pathologists to stain for mast cells. So I'm like, here's my firstborn that'll help you in the lab. Please do this. So I actually end up finding, I align myself with gastroenterologists who then find a pathology department that's willing to do the staining. And then even if you get the staining, some pathologists don't want to call it. So you can always submit a second opinion to both Stanford, Mayo, or Brigham to help secure that diagnosis. And by the way, the individuals that have hyperalpha-tryptosemia or monoclonal mast cell activation syndrome, again, the mast cells don't cluster as much in systemic mastocytosis, in HAT as much as systemic mastocytosis, but they are clustering and they are upregulating CD25. Oh, I'm sorry. I was having fun with that. So this is just to give you an idea about what a normal mast cell looks like. They're small and round. And then when they start to spindle shape, that's the second arrow, and they start to cluster, you need to be concerned that the mast cells are at a higher level of inappropriate activity. Then when it comes to the mediators, steroids can potentially help, but you're really talking about either reducing susceptibility to degranulation or using medications to target common mediators such as histamine blockade, leukotriene antagonism. I'm a big fan of tricyclic agents because it goes after all 3 histamine receptors as well. The medications to the right are focusing on individuals that actually have increased burden of abnormal mast cells. So they've either secured the diagnosis of indolent, smoldering, or advanced forms of systemic mastocytosis. And then this is to give you an idea of all the therapies that I've utilized in patients who I think have mast cell disease. And I have to tell you, I have one study where I looked at individuals that I had over close to 975 patients that came to me solely with the complaint of I have mast cell disease. So after I had my calming tea, I tried to listen to their story. And what I found is 1 out of 5 of them had evidence of hypermobility mast cell activation disease because, again, I'm only able to get a tryptase and 24-hour urine collection of methylhistamine. And you have to hope that the lab, sends that off in time, so it doesn't break down. It's a bad test as well. So I try to give them as much therapeutic response, but also I try to validate them. A lot of times I treat mast cell activation syndrome like that red light that comes on your car. Just if something's wrong, you need to just figure out what it is. And it's an old story, and it dates back to even Francis Peabody, who was like a superhero in the golden age of medicine, where he basically felt one story that he gave was out of the three things he was concerned about is the dehumanization of patients when they're in the hospital. And there was this one woman who had come in, and literally he had said that she had suffered at the hands of so many practitioners. And Boston Hospital was all geared up. Washington Hospital was all geared up to take care of this patient. And they do the testing, it's all normal. And so the first thing the intern says is, there's nothing wrong with her. I wasted all my time and effort. And he's like, and back in 1927, he's saying, we've done all the scientific testing that's available, and we cannot understand why you can't eat certain foods. So I'm going to give you this tonic. Good luck. God bless you. And off she went to the Christian Scientist. That's literally what he said. She went off to a Christian Scientist in that paper. This is the workup that was recently put forth in the research paper by the Quad AI Mast Cell Disease Committee on how to evaluate somebody that has mast cell activation syndrome. So again, 2 or more organ systems in order to secure the diagnosis of mast cell activation syndrome. So somebody who just has urticaria or just has GI upset does not meet the criteria of mast cell activation syndrome, but does not exclude the fact that mast cells may be contributing to their disease. Once they meet the criteria, you need to figure out, well, is this a clonal disease or is this a secondary mast cell activation issue? The one we're most familiar with is allergen-driven, but you also have evidence of high antigen loads, especially with IgG-mediated hypersensitivity. I've actually had that happen with a woman who was accidentally vaccinated by her primary sooner than she'd have, and she actually had anaphylaxis to the vaccine. And there are actually studies looking at the ability of vaccines from the antigen itself causing a hypersensitivity disorder. Look at the biopsies, skin biopsies, go back to how many people have IBS in this country? Like 40%. You need to have a gastroenterologist. They'll look for eosinophils all day long. That's very easy. You have to use special stains for mast cells. Otherwise, they're hiding like ninjas. You won't see them. And then if all the testing is negative, please give the patient the benefit of the doubt. Something's up. And so I try to evaluate, do they have a unidentified or underdiagnosed autonomic neuropathy, like POTS, or do they have an undiagnosed immunodeficiency? I have to tell you, I've identified 27 patients who had idiopathic CD4 lymphocytopenia. And they were complaining about hypersensitivity issues. It wasn't like severe infections. And that actually was addressed and I think I talked about it. So let's talk about the different mast cell phenotypes and endotypes in the last few minutes. So the majority of the patients are secondary mast cell activation disease. HAT falls into its special as a primary mast cell disorder, along with systemic mastocytosis, vibration-induced urticaria, because we found a gene, and monoclonal mast cell activation syndrome. Everyone else, mast cells are being good cops following bad orders. So this is, again, how to secure the diagnosis for systemic mastocytosis, 1 major criteria and 1 minor criteria, or 3 minor criteria. Minor criteria consist of large burden of mast cells on biopsy, greater than 25%. You have a positive PCR, H16V. You have upregulation of activation markers, and of tryptase and activation markers. So CD25 is the induced protein. This is the paper that was put forth regarding the vibration-induced anaphylaxis. I actually have 2 individuals, a nurse who actually had anaphylaxis while on a treadmill, and I had a trumpet player, and every time he hit a vibrato, it was like that. And this is a gentleman who I took over a private practice in New York, and the allergist was in this New York Times cold case study, and he actually had anaphylaxis to cold. So anybody who has the physical urticaria, actually, I was at a meeting. I was actually at the immunology meeting in Hawaii, and I was talking with this researcher from Mass General, oh no, from MIT, and she actually has exercise-induced pruritus, and I'm like, you need to have that evaluated. It's just annoying. I'm like, no, no, no. Just like I still carry my EpiPen from Dr. Sheffer for the past 25 years. And then this is the interesting story about hats. These individuals, again, 5 to 6% of the European ancestry are at risk for having it. It's autosomal dominant, but it's not complete penetration of each one of the three of the triad that's been promoted in autonomic neuropathy, mast cell activation issues, and musculoskeletal hypomobility. This is just, again, how I go about evaluating these patients, and you'll have my slides. Really important to rule out things that mimic mast cell activation syndrome, and I'm just going to highlight three of them. One, complement abnormalities. They're more common. Just like they say, like anaphylaxis is not rare, complement is not rare. They're finding more variants than we know. Actually, an eighth one, I believe, eighth one was recently identified. That makes you susceptible to complement-mediated hypersensitivity reactions as well. This is an interesting story. So regarding Ehlers-Danlos, I'm sure you've seen plenty of people who come into your office, and nothing like someone who's self-diagnosing off of WebMD. But that being said, there are 14 variants of Ehlers-Danlos syndrome. 12 of them have genetic markers. The most common, hypermobile, does not. But the recent data shows that it looks like a variant in the kallikrein system that may be responsible for or travels with the hypermobility in these individuals. And the 12th form of Ehlers-Danlos syndrome is actually a gain of function C1R and C1S. So it might not necessarily be Ehlers-Danlos as opposed to an acquired musculoskeletal hypermobility issue. And then this is just to show you that there's a very strong relationship, again, between the nerves and the mast cells. There's a study that I believe I put in here, yes, between, again, allergy immunology. This is a team effort, and I'm not talking like the Kobe Bryant team effort where he says it's me. It is various disciplines that need to be working together, and this is a joint effort between neurology, and allergy immunology at Brigham and Women's. And what they showed is if you have a diagnosis of an autonomic neuropathy and you have HAT, you're much more likely to have increased susceptibility to decreased brain flow, blood flow. Not a good combination to run with. So in many ways, I kind of lean into what Matthew Hamilton said in a paper back in 2018. These patients come through. We recognize that there's a rise in hypersensitivity disorders. We're now starting to appreciate the role of the crosstalk between the nervous system, but we really don't have great testing available for the nervous system, and we need much more efforts and try to identify the different mast cell phenotypes that may be contributing to the person's symptomatology when they come to see you. This is just a list of the different secondary mast cell activation disorders. So the mast cells are just jumping in because something they think is going on is wrong, and they're just responding to the 911 call. I'd like to emphasize that idiopathic anaphylaxis, there was a report maybe 2 years ago that showed that these are individuals, it was not in the US, they went ahead and found individuals that were labeled with idiopathic anaphylaxis, and they went ahead and tested for alpha-gal, and 1/3 of them had alpha-gal. So this is on the rise, not only in the US, but everywhere. And again, it's interesting to see how an infectious agent will lock your immune system into a type that puts you at risk for hypersensitivity to innocent substances. And I'd like to highlight some of the work that I had done with Dr. Hugh Sampson, who took peanuts off of airlines for a minute, along with Schumann Lee. The work that Schumann Lee did, so Dr. Sampson has been supporting Dr. Lee's work for the past 20 years. And what she does is she uses Chinese herbs that are known, such as berberine, that contain berberine. And she also uses acupuncture and acupressure. So again, she's trying to calm down that conversation between the mast cell compartment and the nervous compartment. And actually, her data is actually quite robust for skin, not as much for gut. But there's something to be looking at in the next few years, because I have to tell you, the pharmaceutical industry is very interested in trying to understand this crosstalk between the mast cells and the nerves, and what we see regarding migraine medications that are on every other TV commercial. Again, this is just emphasizing that alpha-gal seems to be something to consider if you have somebody who's having hypersensitivity reactions. Just another test to add when you're doing serological testing. And I'm going to, this is Charlie Cunningham Rundles. That was interesting. As you know, the allergy and immunology programs, they have strengths. I was fortunate to train for the first half of my fellowship in Boston, so lots of exposure to mast cell disease, as well as immediate hypersensitivity disorders. And then coming down to New York and finishing there, plenty of exposure to food allergies as well as immunodeficiency. And I can tell you, in that population I told you about with the hypermobility, they also have various versions of hypogammaglobulinemia, everything from common variable immunodeficiency to selective IgA deficiency. And so something's going on. And as Francis Peabody had said many years ago, only a few people who just have nothing really wants to go into the hospital or spend their time and money in a doctor's office. You really need to kind of give them the benefit of the doubt. I just had dinner last night with a neurologist who I have a lot of collaboration with. I just found out that her daughter went into University of Pennsylvania with abdominal pain. And the first thing that the intern wrote was she had anxiety until the blood test came back positive and she had to have her gallbladder out. Oops. So I'm gonna move it up. Just a reminder, mast cells play a key role in border defense and homeostasis. They're ideal first responders because they have an array of pathogen receptors, and they also have a bunch of chemicals that contain various types of dangers or imminent dangers as well. We need to better understand the different mast cell subsets in order to have better diagnostic and therapeutic interventions. There are only a few studies of cohorts looking at mast cell function, and again, mostly focusing on HATs as opposed to other cohorts outside of IG-mediated disease. And a lot of the IG-mediated diseases really has a tendency to focus on the adaptive immune compartment, and now we're making our move to the border and looking at alarmins. But where do the alarmins go to? And I think, and mast cells are right up front and receive. They have receptors that can detect a lot of tissue damage and also the alarmins as well. And I think we also need to kind of lean into more on the third most common form of mast cell dysfunction, and that's neuropsychiatric. We've not been trained on it. I can appreciate it. It's just important to identify someone who has clinical interest and expertise in this to help you have this patient get under better control as well. And I have to tell you, I was a lab technician at Rockefeller in the middle of the AIDS epidemic and the rise of asthma and hypersensitivity disorders. And this woman came and gave a lecture, and she is a bad. Her story is very interesting. So she started off as a cocktail waitress in La Jolla, and near Scripps, and apparently at the table were two scientists from Scripps, and she asked a question after overhearing their conversation. She's like, "You should go to graduate school." And so she went to graduate school, and she then became the head at one of the divisions at NIH. But her claim to fame is she's one of 3 scientists that used her dog as a co-author. And actually, she ended up banned from the Journal of Experimental Medicine for years, despite all her good works. And her good works were putting forth the danger theory on how you might lose tolerance. And I think that's where we are now, is we have individuals that are in constant fight or flight, and the responders are staying on high alert because of it. I want to thank you for your attention. Hey, not too bad. Welcome any questions, and literally I stand on the shoulders of some phenomenal individuals. I love this field and welcome any questions or concerns or comments.
There's a question in the chat.
Oh.
Um, why do you think RGC, IgA is interested testing? So what do you think of it? Is there any ongoing food testing study targeting MCAS to receptors given the adaptive response to MCAS? Would this be a problematic or worsening hypersensitivity?
So leaving Hugh Sampson and going to work for an organization that now sees 80,000 patients per month, allergy immunology groups, he would be horrified that I test routinely for IgE to foods. I still don't test for IgG to foods because it's not about the mugshot, which is what I think IgG and IgE is. I think it's identifying why that antibody would actually cause a problem in that individual. So what's causing the danger signal that IgE and IgG would signify that? And I've not seen, and my concern about IgG testing is people will start pulling foods out of their diet. We're already seeing this issue with parents and children. They start reducing their diet and you can end up nutritionally compromised. It's like driving blind. So I'm not in favor of that. Until we have more robust testing. I think I'm a little bit more excited about the basophil activation tests, but even still, that's still, I think the sensitivity, and here's the thing, they've been doing IgG testing for like, what, 40 years? And I've not seen any robust testing to say, if you have this positive test and then you eat this food, it's going to cause a problem. I'm still trying to wrap my head around people who put food in one hand, that muscle testing. We're not there yet at all. Regarding the MERG testing, there are a lot of variations of that receptor. And yes, it is now under active investigation to try to understand. The drugs that they recognize, we use regularly. I was an intern when trovafloxacin was available. Anybody even remember trovafloxacin? Yeah, it's flu. It's a fluoroquinolone that was considered a game changer in gastrointestinal infections. It blew out a few people's liver, so it got pulled from the market. So it's not available here in the US, but it is available in other countries. So that goes through the MERG receptor. So, and there's certain anesthetics that go through it as well. So I think it's really important to identify individuals who are at risk for having hypersensitivity reactions. And then if you look at the Mast Cell Disease Society recommendation of medications that you should avoid in people that may be at risk for having hypersensitivity, a lot of those medications actually go through either the MERG receptor, the opioid receptors on mast cells and bases. Okay, that was a New York minute, huh? And by the way, if you have any, so I'm the medical director for the Ehlers-Danlos Society at Medical University of South Carolina. So if you have patients who have Ehlers-Danlos syndrome or suspected mast cell activation disease or autonomic neuropathy, feel free. The center will be opening up in July, so feel free to send patients for evaluation.